Welcome to Pupil Pod, where we use clinical cases to guide discussions on board review topics. I'm your host, Ogul Uner, and my guest today is Dr. Scott Oliver. Dr. Oliver is the Vitaly Schlesman Chair in Retinal Disease, the Director of the Eye Cancer Program, and Program Director of the Vitreoretinal Surgery Fellowship at University of Colorado School of Medicine, and I'm so excited to have him on the podcast today. Dr. Oliver, thank you for joining me.
Thanks all very much for the invitation.
Great. We will dive directly into our case. So we have a 60-year-old man who presents with new flashes, floaters, and blurriness in his inferior field of vision out of his right eye for the past day. He's pseudophakic in both eyes, but otherwise denies trauma, recent eye surgery, or any other eye diseases. His most recent refraction showed a spherical equivalent of -9 in both eyes. The visual acuity in the right eye is 2400 with a relative afferent pupillary defect and 20/20 in the left eye. And on exam, you know pigmented cells in the anterior vitreous, a posterior vitreous detachment, a horseshoe tear at 12 o'clock adjacent to an area of lattice degeneration, and retinal detachment from 11 to 1 o'clock in the right eye. You also note superior and temporal lattice degeneration in the left eye, but no breaks, tears, or detachments on your scleral depressed exam. Dr. Oliver, what are your initial thoughts about this case?
Well, thanks for presenting this case. This is really a bread and butter, down the line, middle of retina clinic, sometimes Friday afternoon case that walks in. And at face value, it might be very straightforward, but I think it's always really, really important to pause when you're evaluating a patient like this to make sure that everything lines up and makes sense. You present a history of a patient who's a high myope, who has symptomatic vision loss, a detected horseshoe tear, Schaefer sign. It certainly is suspicious for a Rhegmatogenous mechanism. One thing that jumps out to me is the afferent pupillary defect and the really terrible vision. Now, with a small detachment just from 11 to 1, I would want to know, is this a macula-off or macula-on detachment on clinical exam? Sometimes you can't tell, but do you have more information for me?
Yes, those are great points. You do note that the macula is off when you perform a optical coherence tomography scan through the macula, which does explain the poor vision, as you said. What do you think about the lattice degeneration that is present in both eyes?
I'm certainly not surprised to see lattice degeneration show up on exam in a patient like this. We know that lattice degeneration is very common. Approximately 20 to 25% of the population in the United States has it, and it's certainly more common in high myopes. I appreciate that both eyes were dilated. That's standard practice for us. Whenever we're evaluating a suspected retinal tear or retinal detachment, you must evaluate both eyes. And very commonly, if you're evaluating a patient who proves they have a retinal detachment, you'll find pathology in the other eye. Some papers have noted up to 40 to 50% prevalence of a vision-threatening lesion that could cause a detachment in the contralateral eye.
That's such a huge percentage, and thank you for bringing up the importance of dilating the fellow eye. And we talked about your concern for a rhegmatogenous retinal detachment in this case. Could you tell us the different types of retinal detachments?
You bet. So we'll start with rhegmatogenous since we already brought that up. Rhegma in Latin means break. It means that there's a hole or a defect in the retina. And the holes in retinas can take a variety of forms, ranging from small atrophic breaks that occur in lattice, to small tears. Some of them operculate, some don't. They can be larger tears that fish mouth, and then if the tear extends greater than 3 clock hours, we call it a giant retinal tear. But for each of these, the unifying factor is that there's a defect, a discontinuity in the neurosensory retina, which allows fluid from the vitreous cavity to pass underneath it and cause the retinal detachment. That should be distinguished from other forms of retinal detachment. And trainees early on work hard to try to differentiate those. Your first signs that you might be looking at a retinal detachment is a glassy appearance or perhaps corrugation or concavity to the retina. You can lose details of the underlying choroid, so you should suspect subretinal fluid if you're not able to see choroidal detail underneath the retina. But your next job then is to try to figure out the mechanism of that detachment. Not all detachments are due to a retinal break. Exudative detachments can occur for a variety of reasons. One of the most common causes that I see in my practice is a mist tumor. Neoplasms are notorious for causing exudation, whether it's a metastatic or a primary tumor. And you don't want to book a patient for the operating room only to get to the operating room and find out there's no hole to fix, but rather there's a missed cancer. Inflammatory diseases can also cause exudative retinal detachments. And so it's really important for every single patient to take a thorough history and read through the medical chart. Another mechanism that can commonly cause retinal detachments, although these tend to appear rather differently, are tractional retinal detachments. Now, tractional retinal detachments do not start with a hole in the retina. Rather, they start with some contractile force, usually on the surface of the retina or the preretinal surface, but sometimes underneath the retina, that tugs the fragile tissue of the neurosensory retina. And with enough traction, it is able to cause accrual or accumulation of fluid underneath the retina. If the membrane pulls hard enough, it can cause a tear in the retina. And this is called a combined tractional and rhegmatogenous retinal detachment.
Wow, what a great response. I love how you separated them into the different categories. So we talked about rhegmatogenous retinal detachments, serous or exudative retinal detachments, and tractional retinal detachments. And apart from a retinal detachment, when you see a lesion that appears to elevate the retina, or you think it's a retinal detachment, but you're not sure, what else are you thinking about? What else is in your differential diagnosis?
That's such a great question because we can so easily be biased by the chief complaint or the referral diagnosis. And the first thing you need to do if you think you're about to go in and look at a retinal detachment is pretend that no one told you that. Instead, walk into the room, talk to the patient, ask them about their symptoms, review that history, review the other physical findings, and see if everything makes sense. Because a lot of things can imitate a retinal detachment. One of the more common things that we find is a patient who actually just has vitreous hemorrhage. Whether that vitreous hemorrhage is from a hemorrhagic PVD or from a bleed from proliferative diabetic retinopathy, a crescent of blood distributed throughout some of the sheets of the vitreous can have an arc shape to it that imitates retinal detachment. Usually, these can be differentiated with careful examination. I rely on my 90 diopter exam specifically for that to be able to look in high detail. And you want to ask yourself, am I seeing retinal vessels? Am I able to see details of the true retina, folds, corrugations, tractional concavity, that helps me to know this is retinal tissue? If you don't see those things, it may not be the retina. Remember, there's a layer underneath the neurosensory retina. It's the choroid, the often misunderstood or sometimes overlooked tissue layer, which also can elevate. Now, I see a lot of choroidal melanomas. That's a very common reason for dome-shaped elevations, and those get mistaken for retinal detachments all the time. But choroidal detachments can occur due to infiltrative disease, whether it's a granuloma or a lymphoma. They can occur due to a serous exudative process, so a choroidal effusion in the setting of hypotony, inflammatory disease or medication use, or hemorrhagic choroidal detachments. Those have a different appearance. Typically, if there's blood in the choroidal elevation, it's going to appear more dark. Those can imitate uveal melanoma. They also tend to have a dome shape, but they don't follow the same configuration lines of standard retinal detachments.
Yes, those are great points. I really liked how you touched on several different points, ranging from neoplasia to inflammation. Something that we also think about that is commonly tested is retinoschisis, which is separation of the inner retinal layers, generally in the outer plexiform layer in the degenerative form. And some things that would be important, especially for test taking purposes, is that these tend to produce absolute scotomas rather than a relative scotoma with a retinal detachments. They do take up laser because that RPE is intact and adjacent to the retina, so there's no fluid in between the neurosensory retina and the RPE, and you don't see shifting fluid. But if you do have outer retinal holes in the setting of retinoschisis, you could get a rhegmatogenous retinal detachment. And speaking of retinal detachments, what are some risk factors? You mentioned high myopia. What else are you thinking about when you're taking history to identify risk factors for rhegmatogenous retinal detachments?
Certainly. So this patient is sort of a textbook case, whether they're a high myope or they have known or newly detected lattice degeneration or other abnormalities of the vitreoretinal interface, particularly in the peripheral retina. Age is a risk factor for PVD because remember, as the vitreous ages, it tends to contract. As that collagen contracts, it pulls inward. So remember that the main group of patients that we're seeing who have posterior vitreous separations, those that pull horseshoe tears, are those typically in their middle to early later years.
Yes, age is a big factor. We also mentioned, a family history of retinal detachments, as certain hereditary vitreoretinopathies or other vitreoretinal interface abnormalities could certainly cause that. And trauma is another important one to know. But as you said, this is a very textbook case in a high myope who has lattice degeneration.
Absolutely. If you have a patient who doesn't fit the standard demographic, but you look and you see a retinal break and you know it's a rhegmatogenous detachment, or perhaps that's suspected before you walk in the door. There are some other categories that help me to know whether or not to suspect that it's a detachment of the retina or perhaps some other diagnosis. Certainly, family history of retinal detachment can be very useful, particularly premature rhegmatogenous detachments. We have a large cohort of patients with Stickler syndrome, which is the most common connective tissue disorder that's associated with rhegmatogenous detachments. And when you get to talking to these families, you will find multiple generations who've had retinal detachments, sometimes in early childhood, many of whom have had very poor visual outcomes. And they're often very well versed in the terminology that vitreoretinal surgeons use. There are other less common syndromes, such as Wegener or VCAN associated vitreoretinopathy. So if you're seeing a younger demographic with retinal detachments, you need to think about something that might be a syndromic cause. There are a few other predisposing anatomical abnormalities of the peripheral retina, and it turns out that these anatomical abnormalities are very common. Vitreoretinal tufts, I see all the time in the infants that I examine for retinoblastoma. And a tiny vitreoretinal tuft, which is a white elevation of the retina, can imitate retinoblastoma, but they are different. It still has translucent characteristics. It looks like the native surrounding retinal tissue, and it's also in the classic supranasal location, usually adjacent to one of the dentate processes of the ora serrata, which you should remember are more prominent nasally than they are temporally. You can find those small tufts. You can also see meridional folds in these locations. And most of us are born with these. Most of those who have them are born with them and they have no idea that it's there. And for the vast majority of patients, those lesions don't cause problems. But when they get a PVD, there's a little bit of focal traction that is concentrated at that point in the retina, and they can develop a retinal defect there.
I appreciate the breadth of lesions that we talked about, and we'll get back to some of those lesions in greater detail. I think we would love to learn more about the clinical features of rhegmatogenous retinal detachment that you look on exam. You mentioned the Schaefer sign, let's talk a little bit more about what that sign is and some of the other features that you look for.
Sure. So Schaefer sign or pigment in the anterior vitreous is classically associated with a break in the retina, and it's thought to be due to liberation of RPE cells that have passed through the break. And if you see pigment in the anterior vitreous or Schaefer sign, it's your job to look very, very carefully for the retinal break. And then if you don't find it, you need to look again. And I hold myself to exactly the same standard. The other thing that you should do is ask, why else might there be pigment in the anterior vitreous? Because a break in the retina is not the only cause. Patients with pigment dispersion syndrome will often have bilateral pigment in the anterior vitreous. Marfan syndrome or other abnormalities of highly mobile iris lens diaphragm can also have some chafe. Patients with UGG syndrome can develop pigment in the anterior vitreous, and an antecedent history of trauma raises that risk as well. Some of those features are different. You need to ask about the history. Frequently, you can sort it out. But if you do see pigment in the anterior vitreous, it's actually a great clue. Most of the time, it means that you will be able to find a retinal break. The problem is not all retinal breaks leading to retinal detachments have Schaefer sign. So it's our job as ophthalmologists and as vitreoretinal surgeons to find the break anyway.
Yes, I appreciate the high standard that you mentioned that all of us should aspire to do because it's so important and these can be vision threatening. We talked about the corrugated appearance. The intraocular pressure can sometimes be different. It's generally low, as we talked about, but sometimes it could be high. So that's a commonly tested question. A syndrome called Schwartz-Matsuo syndrome, where the liberated photoreceptor and RPE cells can plug the trabecular meshwork, is the thought. So sometimes you could see it as high IOP. And you also talked about the corrugated appearance.
Sure. So disruption, I'll just say a small comment about disruptions of intraocular pressure. Um, that helps once in a while, but frequently those are associated with either a chronic or a very extensive detachment. Okay, so the problem is the thing we all lose sleep over is the small horseshoe tear that you miss that leaves the patient mac off the next day. If a patient has an extensive detachment, then they can present as hypotenuse. But it's pretty easy to find those detachments. For patients who have chronic detachments and they have some liberation of either pigment or the photoreceptors and they develop a secondary glaucoma, then sure, you've got a tip off with that asymmetry and the intraocular pressure, but it's probably a big enough detachment that you'll be able to find it. One other finding I'll mention is iris retraction syndrome. So if you see hyper deepening of the anterior chamber, this is caused by disruption of the aqueous currents associated with the retinal detachment as the aqueous fluid produced in the ciliary body distributes abnormally into the vitreous cavity. There can be hyper deepening of the anterior chamber. And if you see that, dilate and look at the retina as well.
That's great. Thank you for that great tip. And so, moving on to treatment, how do you treat a retinal detachment?
Well, in some ways, I find that our trainees can be perhaps a little overwhelmed by the variety of choices to fix a retinal detachment caused by Rhegmatogenous mechanism. It's actually pretty simple. If there's a hole in the retina, you need to plug the hole. And there are a variety of ways to achieve that goal, but until that hole is closed, the retina will not be able to successfully reattach to the retinal pigment epithelium. So every treatment that's utilized to treat Rhegmatogenous detachments centers on that basic principle. The hole must be occluded, the retinal break must be closed, and many of you know that we'll insert a gas bubble with or without a vitrectomy. The bubble's surface tension occludes the break. So it's not a principle of buoyancy. You don't get enough lift out of a 4 cc bubble in the posterior segment to float your retina back in place, but rather the bubble simply occludes the hole. And you can test this out if you have burning curiosity the next time you're in a swimming pool. Take a plastic bag and blow bubbles into the plastic bag and experiment with different sized holes in the plastic bag. And you'll see that the bubble wants to stay intact rather than flow through the hole. And this is why bubbles inside the eye help us to close breaks and reattach retinas. Principle of scleral buckling can be a little bit hard for people to visualize, and it has to do with fluid dynamics. Often my residents and early fellows feel like there's a voodoo magic that has to do with why scleral buckling actually works, but it does. It has to do with the way that fluid flows over a defect in a membrane. There are some nice demonstrations of this, some experiments done in slosh tanks. Think of an aquarium that's got some fluid in it and a membrane with a hole in it. If you slosh the fluid back and forth, it will cause that membrane to float up. But if you put a rock or another round object underneath that break, the way that the fluid travels across that hole will actually slowly cause that membrane to pump down. And so by indenting the wall of the eye, bringing the wall of the eye into closer proximity with the retina and changing those fluid dynamics, retinas are able to reattach when a scleral buckle is placed in the right place. So it's a retina surgeon's job to get it in the right place. And that's a pretty steep learning curve. You won't learn it overnight. First job is to identify all the retinal breaks, and next figure out how to sew an exoplant onto the eye to occlude those breaks. But it's very successful, just as working on the inside of the eye and occluding the break with a bubble of gas or oil also works.
Wow. Thank you so much for that great explanation. I learned so much from that. And I will definitely be trying the water and bag experiment when I am in a pool next time. And one of my retina mentors similarly always said, the job is to find the break, to seal the break, either with laser or cryotherapy, and then plug the break, whether that's with gas, with oil, with air, or with a scleral buckle. So thank you for that answer. We talked about some peripheral retinal lesions that we should know. You briefly mentioned about tufts and folds. What other lesions we should know that predisposes eyes to rhegmatogenous detachments?
One of the things that we think about a lot as retina surgeons is the location of the vitreous base. The vitreous base is a little bit of a mysterious structure until you've spent some time with it. Recall that you can never take all the vitreous out unless you cut out the far peripheral retina of the vitreous base. So this is typically, classically, considered to originate about 2 millimeters anterior to the ora serrata and 4 millimeters posterior to the ora serrata. And this is the reason that when a patient has a PVD and you're looking for that retinal break, you're not actually trying to see the ora. Most residents are desperately, desperately hoping that they can find the ora serrata, but most of your tears happen at the posterior edge of that vitreous base. Now, there are tears that happen within the vitreous base, and especially in pseudophakics, you can get them more anteriorly, so you do need to examine the whole retina. Patients also can have different vitreous bases. Eyes are made differently. So some people have very posterior vitreous bases. We see that in pediatric rhegmatogenous detachment. We see it in patients who have survived prematurity, who are adults with ROP. Sometimes their vitreous base inserts at the equator or even as far back as the arcades. We think that patients who have giant retinal tears have a very short or thin vitreous base, and often their tears can have a slightly different configuration that perhaps predisposes them to the GRT, at least in cases of GRT that happen without trauma.
I think that there's so many different things to consider, and again, comes back to the importance of taking a history and looking at your demographic, as you mentioned earlier. And so, in this specific patient with a superior rhegmatogenous retinal detachment, how would you treat it, and how would you counsel them?
That's a great question, and I think that needs to be a discussion with the patient. I practice in Colorado. We are based at 1 mile high, 5,280 feet, but a lot of our patients come from higher elevations. So I think if you ask most vitreoretinal surgeons about a detachment, pseudophakic detachment, superior with this configuration, they'll select either pneumatic retinopexy or primary vitrectomy with typically a gas bubble for endotamponade. And those are very reasonable. That we handle most of these cases with primary vitrectomy. But you also have to be prepared for the patient who lives at 10,000 feet or has to go over a 12,000-foot pass and think about, what are my other options? Could you fix a detachment like this with a scleral buckle? Absolutely. Could you fix a detachment like this in a compliant patient with pneumatic retinopexy? Yes, but be careful not to miss lattice degeneration elsewhere in the eye, or you may pull a break at another location and then fail and have to go to the operating room.
I really appreciate you bringing up the importance of, talking to the patient about the different options. and what really works for them.
For
So,
all of our surgeries to work in retina, we must have patient engagement. And the patient doesn't need to understand everything about retina surgery, but they do need to understand enough for why the instructions that we give them postoperatively matter. There's one other procedure that I would consider critical in addressing this patient's concerns, and that's laser retinopexy to the other eye. So by performing laser retinopexy to the lattice degeneration on the other eye, you reduce the risk that that patient develops a detachment in that eye and suffers the same fate and the same risk of vision loss that they've endured in the right eye.
thank you so much for that input as well, especially for the fellow eye. So let's summarize what we learned from Dr. Oliver. Retinal detachments are separations of the neurosensory retina from the underlying RPE, and they're categorized into three broad groups. We talked about rhegmatogenous, serous or exudative, and tractional retinal detachments. And rhegmatogenous detachments are due to breaks and fluid tracking into the break, causing the neurosensory detachment. They typically have a positive Schaefer sign, which is the presence of pigmented RPE cells in the anterior vitreous, and the retina will have a corrugated appearance. The treatment is based on finding the break, sealing the break, and plugging the break, which could be done with laser and cryo for the sealing and plugging via air, gas, oil, or scleral buccal. Pars plana vitrectomy is ideal for patients who are already pseudophakic and have complex retinal detachments that may require silicone oil, whereas scleral buccal is a great option for patients who are young, don't have PVDs, phakic, and may have difficulties with post-op positioning, as well as living in elevations. Pneumatic retinopexy is limited to detachments in the superior 8 clock hours of the retina and single or multiple breaks within 1 clock hour. And we talked about different peripheral lesions like lattice degeneration that may need prophylactic treatment depending on the retinal surgeon's preference. Generally do not unless they're symptomatic, though laser treatment prophylactically in fellow eyes after an eye has had a rhegmatogenous retinal detachment is considered. And we talked about the importance of lifelong monitoring of these patients with strict return precautions if they do have new symptoms. Anything else you would like to add, Dr. Oliver?
I would say that's a great summary of rhegmatogenous retinal detachment and the tears, breaks, and holes in the retina that can lead to it.
Thank you. And Dr. Oliver, before we end the episode, I ask all of my guests a question. And my question to you is, if you could go back in time and give your younger self one piece of advice, what would it be?
That piece of advice would be trust the training and the principles that you've learned and that you've internalized. Set your sights high, and then believe that you will get to where you want to be.
Love that. Very inspirational and something that we should all aspire to do. So thank you so much for that answer. And Dr. Oliver, thank you for joining us on this episode of the Pupil Pod.
Thanks very much, Joel. Have a great day.
Thank you to our listeners. See you next time on the Pupil Pod.